you as far as what's supposed to happen. After the cord has been clamped, then and the baby takes the first breath, then the oxygen should help to decrease the pulmonary vascular resistance. And if the PVR decreases, then you've got now. Have we talked about Heliox? Can anybody remember Heliox from chapter, was it 18 last week? So chapter 18, just if you don't remember much about it, just go back. There was a section that we spent talking about Heliox. If all you remember is lighter, you're going to have to go back and again just read up on what's there. Rise faster. Well, I mean, think about like a balloon that you inflate with helium. The balloon is always trying to trying to leave because of the fact that helium is so much lighter. It's just trying to go out into the atmosphere. Yeah, so and that question, it was more so this was a situation where you got to just think about the properties of helium and oxygen, with helium being much lighter than oxygen. And because we used a head box or oxyhood, then more than likely the helium was just kind of accumulating at the top of the oxyhood and it wasn't reaching the baby's nose. Okay, yeah, so the flow rate, we didn't know what the flow rate was, but again, if the flow rate was not enough, then the saturation probably wouldn't have improved either. So that question presented, it looks like it's partially working because saturation is better. So again, that would just say that if you had flow over flow, the baby would still be desaturating and still working really hard to breathe. Now, so the baby takes the first breath. You're welcome. Baby takes the first breath, and then the pulmonary vascular resistance starts to decrease because that's what O2 does to the pulmonary vasculature. It causes it to dilate, and then that would mean that now, instead of the left side or the right side of the system being high pressure and left side being low pressure, everything now transitions to normal like it's supposed to be, with the right side being low pressure and the left side being high pressure. And then these other things that are happening, as soon as that pressure change does take place, then your foramen valley, being that it's just a one-way flap, or it was acting like a one-way flap. I don't want to say one way, I'm just going to say flap, being that the pressures on the right side in utero were higher than the left side, then you end up with blood that's just kind of going by, it's bypassing the lungs and going, or is bypassing the right atrium and going right into the left atrium. And then also we know that the increase in PVR is going to make it harder for the blood to try to go out to the lungs. So then it'll end up going across the ductus arteriosus instead. And then those prostaglandins, or PGEs. So as soon as the cord is clamped, those prostaglandins that were being produced by the placenta are no longer going to interact with the baby. And so that would also, because these are going to act as dilators, they're going to keep like the ductus open. But now that the baby no longer has access to those, then the ductus should start to close. And again, as long as all these things are working the way they're supposed to, then there should be no problem with circulation or the blood flow once the baby's been born. Now, the ductus, as I said before, in the last trimester, they've seen that the ductus is already undergoing some changes. It's starting to prepare to close. And then after birth, it closes. And then over the period of the next couple of days, it's going to close more and until it gets to the point where it's completely closed. But if it doesn't, for whatever reason, close, then, or let's say that it reopens, then if you're suspecting that this is the problem, then what you could do is what's called a pre and post ductal saturation or pre and post ductal oxygenation. And this chapter was written by somebody completely different from whoever wrote the chapter 22, because the first time we looked at this pre and post ductal oxygenation, I believe the last chapter 22 said greater than 20 with the PaO2, so a gradient more than 20. And here we're saying that if the gradient is more than 15, then that would be significant. So because there's always that kind of thing that happens, you got different authors writing different chapters in these books, I'm not going to really ever ask a simple recall question that would say, what is the normal gradient for the ductal saturation or ductal oxygenation? Because it wouldn't make sense to try to like remember if it was greater than 15 or greater than 20. Just know that most times people are just going to use pulse oxes anyway, instead of taking blood and running an ABG to see what the difference is between the PaO2 from the preductal site and the postductal site. So then with pulse oximetry, we know it's so much easier, it's non-invasive. And if there's a difference of more than 5%, so if this ductus is still open, then that means that the postductal will be less than the preductal. And we're looking for about more than 5%. So if the preductal is 5% greater than the postductal saturation, then that should lead you to believe that the ductus has reopened. And then we'll get into the whole mixing business in the next slide. But as far as orientation, the right hand is traditionally used as the preductal site. So you would take a pulse ox and label it. Usually you just probably just take a piece of tape or something, because they'll probably be stacked on top of each other. And you'll just label one preductal and the other one postductal and use the baby's right hand. But there have been some research where they said that the left hand could work just as fine, but it's probably easier just to remember opposite. Like if you're using the right hand for the preductal, then use the left foot for the postductal. But again, as long as it's a lower extremity, it would work. So it wouldn't be wrong to have the preductal pulse ox connected to the baby's right hand and then the postductal connected to the right foot. But again, just for the alternating to make it easier to remember, just make them kind of like or opposites, right hand, left foot. Now in the reading, they're going to say, if you're going to be using your blood gases to check pre and postductal oxygenation, you would take your blood from they mentioned temporal artery or temporal artery if it's a very small baby, or if you had, say, a radial artery catheter in place. That could be preductal blood. And then for the postductal, they mentioned using the UAC or umbilical artery catheter. But again, that's kind of complicated, which is why it's so much easier to just use pulse ox. We always use pulse ox, and it would be just fine. Now here's this guy again. I mentioned that we will talk about it a little bit more when we got to this chapter, but this drawing here is just kind of representing what you'd expect to happen if the ductus is open or has reopened. So why one side would be considered preductal and the other side postductal? It's all about what's happening like with fetal circulation. So like in utero, we know that blood is being shunted from the right side to the left side, essentially. So then if we take a look at what's going on as far as the blood, so the blood has returned to the right side of the heart. And then it leaves the right ventricle and is heading out to the lungs to oxygenate or to reoxygenate. Now, some of it does make its way to the lungs. Or I should just say lung. This is the left lung and the right lung. So some of it will make its way out there to participate in gas exchange. But then if the ductus is still open, some of it's going to end up shunting across and make its way into the aorta. Now, following the blood that has oxygenated, where is this going to get? Okay, so now that blood is still going to return pulmonary veins to the left atrium and then out through the left ventricle into the aorta. And then it's going to meet with the blood that never did make it out to the lungs. And this is where things become a problem. So now you've got mixing or desaturation that happens. Now, preductal would be the blood that has left the left ventricle, and once it leaves the left ventricle, you've got your coronary arteries, you've got your brachiocephalic artery, and your carotid. So that's why all of this is like white, which would be representing, oxygenated based on the guide that they've got here for us. So this is all fine. This is the blood that did participate in gas exchange. And now because it's heading out into the aorta, it's going to the head and it's going to the upper extremities. It's going to the right for sure. So here's like our right common carotid artery, and then here's our right subclavian artery. And so from here, this goes to the right arm, which is why we place the pulse ox on the right hand. And then here everything is now mixed. So they made it here where the left hand would be considered part of the postductal side of things, and definitely your lower extremities. So if your descending aorta, this is our descending aorta here. So your descending aorta, if your ductus was intact and the blood shunted across, then chances are, for sure, your lower extremities are going to get mixed. At least that oxygenated blood is going to get mixed with the ductal blood, blood that just kind of shunted across the ductus. And again, depending on exactly where things are mixing, it could affect your, this is the going to the left hand or left arm. It could affect that side as well. But again, they've done studies to show, depending on just how severe, if it's not a major shunt, if it's not a severe case of PDA, then the left arm or left hand may not be affected. But if it is pretty significant, then it will end up being part of that mixed side as well. So again, just keep it simple and use your right hand to be your preductal. And then everything on the lower extremities is going to be, and the left will be considered your postductal. And again, we're looking for a difference between, like say, if the saturation, and I'm just going to say saturation is 100%, which is what we definitely don't want to see with newborns. But let's just say that saturation was 100% preductal, and then on the postductal, it's reading like 94% or 92%. Then you already see that there's a definite difference between the preductal and the postductal saturation. We're looking for a gradient of about 5% or more to be significant. So if it's just off by a couple of percentage points, it's not that big of a deal. And it may not be an actual PDA. But if it is more than 5% difference between the pre and the post, then we've got to say that we are suspicious that the ductus has now reopened. Okay. So now, this just shows what's supposed to happen after the ductus has closed. It's just now a ligament, or it's just, it's not supposed to be open. And once it does reopen, the purple is representing all the mixing that's taking place. As you see, you've got blood that's going out into the aorta through the ductus, and because of the left side being a high pressure system, you could also get some of that systemic blood mixing with your pulmonary blood. So will a PDA be classified as a purely right to left side shunt, or will it be considered a left to right side, right to left or left to right? It depends. It really depends on a lot of things, but we do know that with that ductus being open, there's always going to be some mixing taking place between the oxygenated and deoxygenated blood. Now, if they did the pre and post ductal oxygenation or saturation, and they see that there's a significant difference between the two, then they'll just pull an ultrasound machine at the bedside, and do like an echo. And from the echo, they're going to be able to see the blood shunting across. And on echo, the color, of course, going to mean different blood types as far as venous blood and arterial blood. And then when they start to see areas where there's some mixing taking place, then that would definitely help to confirm that this is the problem. Now, let's say the baby has been diagnosed with a PDA, and then it might close if it's, if it's not a major problem, it might close, but, it may take about a year before it completely closes or so. And if there's some issues that the baby's having, as far as, there's, your standard like oxygenation problems because of all of like the CHF type of issues that they're going to develop, and then the pulmonary hypertension, et cetera. So then you got to treat those symptoms. You got to treat like the CHF, and you've also got to treat the pulmonary hypertension. So then what can we do? Well, PEEP is positive pressure. So PEEP is going to help to keep the fluid from going back into the alveoli. So it'll help to kind of push the fluid out. And then also at the same time, it's going to prevent the word they use is transudation here. So let me write. Prevent the transudation of fluid. So a transudate is something that crosses over very easily. So you're thinking like a thin liquid. A thin liquid should be able to cross over a membrane pretty easily. And that's usually what happens in things like CHF. You end up with all this alveolar flooding because you've got fluid that's now just really easily making its way into the alveoli. So you give them something like PEEP or CPAP, for that matter, it's going to keep that transudation from happening. Your non-steroidal anti-inflammatory drugs like your Indocin or indomethacin, your ibuprofen, those are going to be helpful as well. What they do know is that Indocin is going to block any PGEs or your prostaglandins. So if there are any prostaglandins that are still circulating, and now the baby's possibly maybe producing prostaglandins that are affecting the ductus arteriosus. So this will block. So it's going to keep your prostaglandins from dilating the ductus, which will make it open even more so. So that's essentially a way to close your PDA, is to give like Indocin or indomethacin. Ibuprofen, they believe that it does kind of the same thing that Indocin does, and that it blocks the synthesis of the prostaglandins, but they're not 100% sure on that mechanism. But everyone's been accepting that and just say, yeah, this is kind of like how it works. In fact, they've manufactured a specific ibuprofen just for babies. It's called neoprofen. And then there's been some other concerns over the years that giving the babies ibuprofen to try to close their ductus will, over time, possibly lead to some chronic issues. They may end up with some chronic problems, like I think they've seen some chronic lung problems, and they tied it back or linked it back to the ibuprofen. So what most nurseries are going to do is they're going to just use Indocin or indomethacin. And then in some cases, they can go in and do some surgery, and they call it surgical ligation, which means that they just have to go in and literally sever that ductus and tie it off. Or just completely tie it off. Now, you'll notice that in this chapter, they do go into some detail with the different surgical techniques if they are going to perform surgery. That's not really where we're going with this material. We're not going to really spend that kind of time to kind of go through and compare and contrast the different techniques that they have. We're going to just say surgery. If there's something that can be done surgically and it is an option, then that is something that could be considered if your drug therapy isn't really working. And then we have, so these are, of course, these are our surgical, these are shunt lesions. So we start off with the PDA, and now we're looking at an ASD. And ASD is something that they probably are not going to show any problems at all. So if you do start to see some other issues develop, you have to kind of like go through your testing and you do your echoes and things like that, and then you may recognize or identify the problem. So, and again, in most cases, they're going to be symptom free. But an ASD is just your foraminal valley, and because of the differences in pressure now outside, meaning that once the baby's born, the right side pressures are lower and the left side pressures are higher. If your foraminal valley is still open, then you're going to end up with a definite left to right shunt. So you're going to have way more blood that's now going into the pulmonary side of the system. You're going to look at it that way. So over time, your right atrium would get larger, and any muscle that has to work harder, so like the right ventricle, is now pumping harder and harder and harder. So any muscle that works harder gets bigger. So we would expect to see the hypertrophy. And then the backflow and all this fluid that ends up kind of just accumulating. You're going to see CHF being listed pretty much throughout most of these heart problems. There's going to be those kind of issues that these babies would be dealing with is the CHF. Okay, so now, because it may not really show any problems and it could never be diagnosed, it may be something that will never become a problem for the baby, and then it may just fix itself. But if it is a significant problem and you're having to treat them because hemodynamically they're not doing that great, then you may have to consider doing some kind of surgical repair. And it's usually like it's a minor surgery that they could use to fix this problem. Now your VSD. Now VSD is going to depend. It's going to depend on just how bad the shunt is. So first, this was not natural for fetal circulation. Now the foraminal valley, of course, was there, but we didn't have anything between the left atrium and the right atrium because there was no need to have another shunt there. So when you have a baby born with a VSD, it could be, it says here, the size of the hole and amount of the resistance to pulmonary blood flow is going to determine just how bad the shunt is in VSD. So we're going to have what's known as restrictive and non-restrictive. Okay. So here we have the CHF kind of thing going on again. So if you got a lot of blood that's now regurgitating back from the left side into the right side of the system, then you're going to have a problem with fluid. And then also you're going to have a lot of resistance to blood flow. So you're going to have a lot of pulmonary hypertension. So then what you're really treating here is all of this extra fluid. essentially. So the diuretics is going to be helpful. And also the inotropes are going to help to kind of get things back in balance. So because you've got way more blood that's now going from the left side of the system to the right side of the system, in some cases, that will cause some other changes to take place. So you could have, say, like your pulmonary vasculature starts to get more thicker. So those vessels start to get thicker, and then that almost creates like a situation where the right side pressures are going to be now almost as high as the left side pressures. So when that happens over time, they call that Eisenmeinger's syndrome. And I'm just going to simplify this and say if PVR increases significantly, so then that's going to cause blood to shunt from right to left. So ordinarily you'd expect this to be a left to right shunt, but in Eisenmeinger's, then they would see one of those situations where blood is going from the right side to the left side. Okay, but again, sometimes they would just have to go in and surgically fix this type of problem for the child. Now, AVSD, atrioventricular septal defect. So this could also vary depending on just the level of severity. If it's not that bad, it'll probably look more like just a regular atrial septal defect or ASD. And as we've seen with ASD, it's not like a life-threatening kind of problem for the child, which means that if they've got AVSD and it's only just kind of like the septum between the atria is mostly affected, and the valve, like the left valve or mitral valve, then it's not going to be that big of a deal. But let's say that you've got no division at all between the right side and the left side of the heart. No septum between the atria and no septum between the ventricles. Now this is pretty bad. And when you see something like this, it's usually the child's probably got Down syndrome. And what will happen in that case is you've got blood going all over the place because there's no division. There's nothing really to keep it separated. So then what do we see? There's of course, our CHF. And now you got way more blood because the left side of the system is still supposed to be your high pressure system. And then you've got now more blood going to the right side. And that could cause a lot of more engorgement on the right side, which would lead to like your pulmonary hypertension situation. Okay, so here we say they may not have any symptoms because it could be a minor case and it could be just almost like ASD. But if it's pretty bad, like where everything is just kind of going left to right, right to left, then that's when, there's going to be some definite problems, and the child is going to have some definite symptoms and signs. Well, I should say just signs, depending on just how small the child is. And let's say that this never got diagnosed after birth, then it can, as they say in some cases, the child won't grow, and they may have a hard time. You think about somebody who is like, say you've got a child who's like trying to just be active, and they may not be able to be really active because of the heart problem that's happening here. You've got, again, no division, no separation whatsoever between your right side and the left side. Now, cardiomegaly, that just represents the muscle getting larger because it's having to work harder. And then saturation of 75 to 90%. Now, that's not terrible when you think about like a newborn. 80 to 90% is usually not that bad. So 75, now we're starting to say that that's pretty significant as far as desaturation would go. So let's say you've got a case of AVSD, and again, there is no septum at all. Then they're going to have to probably go in and do surgery to fix this, because there's nothing else that can be done. You can just try to manage the symptoms, give the diuretics, give the inotropic agents, but really, this is going to at some point require some kind of surgical intervention. So now let me back up. So this was our last shunt lesion. So now we're going into our left ventricular outflow tract obstruction. And let's just go ahead and take a 10-minute break now, and then we'll talk about this group, and then there's